credit Dr. Falgiani put this lecture together, and she actually did a very good job, so I'm just going to use her slides, but give her the credit for putting it together. So we're going to talk about respiratory emergencies today. Okay, basically the goals is to identify the unique characteristics of the pediatric airway, how it differs from the adult, just to get you guys more comfortable, because I think everybody, when they hear a pediatric patient is coming in by EMS, especially in respiratory distress, their panties always get in a wad. We're always concerned about the airway, who's going to have to intubate this patient. So we'll talk about upper and lower airway diseases, and we'll distinguish between the emergencies and urgencies of the patients that you guys will see. So the pediatric airway, how it differs is the head of the patient is usually larger. So they usually, when they're laying flat or on the backboard, and you guys know this, that they're in flexion, so it blocks off their airway. And usually they need some kind of towel or that, I can't think of what you call it, that little gel thing that you put under their head so it opens up their airway. And I have pictures, I can show you that. They usually have a large tongue. They have lots of adenoid tissue, so if you try to pass a nasopharyngeal airway, you'll usually get a lot of resistance, or even trying to pass a nasal tube, it's usually not successful because of that airway tissue that's enlarged. Epiglottis is usually U-shaped, and it's really floppy, so that's why we intubate these guys with Miller blades, not Macs. I will tell you personally, I like to use a Mac blade as a Miller, and it's just whatever you're more comfortable with. And then the larynx is more anterior. And what I mean by that is you kind of have to look up when you're looking in the mouth. And I feel like cricoid pressure actually helps you see the opening of the epiglottis and the airway better if you put some cricoid pressure there when you're intubating these kids. Other differences, the cricoid ring is the smallest diameter compared to the adults. It's usually a vocal cord, and I'll show you a picture of that. The tracheal rings are usually short and very narrow, so it's hard to actually get a surgical airway in if you can't intubate these kids from above. They have a short tracheal length, which means that when you go to put the ET tube in, you want to make sure it's 1/3 of the tube that you're using, because most of us will tend to shove that tube in, and we're going to right main stem it if we do that. And then because they have larger mouths, their airway is actually shorter, so they have a higher resistance when you put the tube in. So this is just a picture, and you can see how it kind of goes down into like a funnel. On the pediatric one is on this side. The adult is on this side. Okay. So some of the things you want to think about, first thing I do when I walk into a room that's a kid of having respiratory stress, I want to look at them and what they're doing, how they're sitting, how they're moving, how they're interacting. You want to, as far as history, you want to ask the parent, how acutely did this come on? Was it a gradual onset? Was it acute onset? Did they go to bed normal? Did they wake up like this? Do they have fever? Are they drooling? Are their voice changes? Are they able to swallow? Or are they spitting out their saliva? Did they have preceding UR symptoms? And any past medical history that may be important, because some of these kids that come in are chronic kids that may have lots of medical issues as well. So again, physical exam. First thing I do, I want to look at the child. I want to see what they're doing, how they're interacting. Are they alert? Are they crying? Are they able to speak if they're an actual older kid? What's their work of breathing? Are they retracting? Are they grunting? What does their skin look like? Are they pale? Are they cyanotic? Are they mottled? And how does their skin feel? I think that really helps. Like, are they diaphoretic because they're working so hard? Or are they just warm and like they normally are, or cool because of whatever's going on? So here's a video I want to let you guys take a look at and see what you guys think. So what do you guys see on the video there? Right. Increased work of breathing. He's got subcostal, intercostal retraction. And usually this is a patient that's going to present with asthma, so that's usually a lower airway disease. And this is just an infant to contrast. It's really loud. So that's called grunting, and usually what the child is doing is they're auto-peeping so that they can improve their airway, opening up their airway and improve their oxygenation. So if you ever hear that, that's a really concerning sign to me. That really gets my red flags up when I hear grunting. Sometimes you'll see head bobbing with that as well. So both those are usually impending signs that the child is in trouble and that they're going to fatigue and tire out and need some kind of help, whether it be an ET tube or some CPAP, BiPAP. Do you guys do that for the pediatric patients today? No? Okay, just curious. Respiratory status, these are just some respiratory rates for infants up to your adolescent. You can see by 4 to 6 years of age, they start to reach adult. And then adolescents, usually by 12 years of age, they have the same rates that we have. Signs of increased work of breathing, you saw it on the video, retractions, nasal flaring, grunting, head bobbing. Those are all worrisome signs. Altered mental status, so if you have a kid that's agitated, it's irritable, it's not really responding, they're lethargic, they're comatose, I would probably be thinking about putting an airway in those children. Look at the skin color, we talked about that a little bit, cyanosis, pallor, those are usually late signs, you don't want to see that. The sniffing position is usually kids that have upper airway problems, so they kind of lean forward and tilt their head up. That's usually a kid that has an upper airway obstruction, whether it be croup or like a foreign airway, a foreign body. And then the tripod position is where they're kind of leaning forward down to try to auto-peep. And that's usually a lower airway disease. When you're listening to them, are they snoring? Are they grunting? Usually you don't need a stethoscope to hear grunting. It's usually pretty audible. Stridor can be audible, or sometimes you need your stethoscope with it. You want to know if they have wheezing, rales, or rhonchi. Wheezing is usually a sign of asthma or bronchiolitis. Rales or rhonchi are what you want to think about with pneumonia. So just some practical points that she put on here. They have unique airway anatomy, as we talked about. Begins with a good history, taking a look at the patient, what they're doing. Like I said, first impression when you walk into the room, that's probably going to dictate what your plan of care is going to be. And then you want to look for signs of increased work of breathing, altered mental status, their color, their positioning, and what you hear on your auscultatory findings. We'll talk a little bit about upper versus lower airway disease. Croup is probably a lot. I feel like I see a lot of you guys bring in the croup patients. The kid goes to bed normal, wakes up in the middle of the night having problems breathing. There's no history of asthma. That's the common finding for croup. And right now it is croup time, so we're seeing a lot of the croup patients come in. You want to think about foreign bodies, and you want to be really suspicious for foreign bodies because sometimes there's not even a history that the child swallowed anything. You know, think about things that we drop on the floor all the time. Kids can just pick it up, put it in their mouth, and swallow it. So you have to have a high index of suspicion for foreign bodies, especially in the lower airways. Epiglottitis, we don't really see that as much since the vaccinations came into place. Strep pneumo and Hib. Since the introduction of that, that's gone way down. Bacterial tracheitis, we'll talk about, that's pretty rare as well. And then you guys see a lot of the lower airway diseases, the asthma, the bronchiolitis, the pneumonia patients, and then again, foreign bodies. So croup, the other big medical name is laryngotracheobronchitis. That's too hard to say, I think. Croup is much easier. It's usually an upper airway disease. Parainfluenza causes probably 75 to 80% of the cases. Other viruses like RSV, flu can cause it 6 months to 3 years of age. Male greater than female, I feel like I see probably equal. And then the winter months, which we don't really have here, so you just kind of think of the winter months if you were up north. They usually have fever, rhinorrhea, nasal congestion, a barky cough. They can have inspiratory stridor. It can be audible, not always. Usually I feel like if they go outside in that cool night air, it usually opens them up so by the time they get to us, their breathing pattern is much better prior to them coming to the emergency room. Some have respiratory stress, some don't. And like I said, the history is usually they go to bed fine. They may have like cough, runny nose, but then they wake up in the middle of the night struggling to breathing, and that's when they usually come in at like 2 or 3 in the morning. They can have fever. They can complain of shortness of breath, increased respiratory rate. The Wesley scoring system, I'm not a big fan of this because if you look at it, it's very tedious. To me, if I have a croup patient that comes in, if they have respiratory distress at rest with stridor and they're actively pretty struggling to breathe, to me that's moderate to severe croup, and I just treat those patients with racemic epi and Decadron. If they have no stridor at rest and they're comfortable, but they're still got the barky cough. They may have a little bit of stridor when you agitate them or make them cry or examine them. That's mild croup, so I'll just give them some saline neb to give them some mist, and then I'll treat them with Decadron. But they do use this score when the patients get admitted, but to me it's just very, very tedious. It's just something for you guys to be familiar with. Usually a score of 0 to 2 is mild. They just do mist therapy, but I will tell you, I give them the Decadron because I don't want to see them come back in the next night with severe respiratory distress. So I go ahead and I do give the Decadron for mild. And then moderate is 3 to 7, greater than 8 is severe. Usually these kids, if they have to get more than 2 racemic epis, either one by, well, you guys don't carry it, I know, but if they have to get 2 in the emergency room, they usually get admitted. Labs, x-rays, they don't really help you. This is more of a clinical diagnosis. Mist therapy, you can do, even just giving them albuterol neb, if you're not sure what's going on, they get some mist from that, so that does help open their airway up. And then racemic epi and Decadron is a treatment. Decadron, the max dose for that is 10 milligrams. And this will just be an example. See here, he's got a little bit of stridor, but more that barky, croupy cough. And then here's just one more. Oops, sorry. So you can see, even though he's working, he's still able to sleep. It's probably more alarming to the parents than it is to the child. Foreign bodies, these can be a true airway emergency, especially if it's a airway foreign body. I've seen where kids get like beads or coins actually stuck in the opening of the epiglottis region. And those kids can have like a ball valve mechanism where it kind of, as they breathe in or you get upset, they can actually occlude their airway off, and then they can go into respiratory failure. And that's not what you want to see. You actually want to try to keep these kids pretty calm. You don't want to agitate them very much. You're usually going to see this under 3 years of age. They can come in altered, or they can come in with normal mentation and breathing fine. Usually candy and food, but like I said, I've seen beads, I've seen coins, I've seen what do you call those things, off the top of like the ketchup bottle, that little foil thing that you peel off. I've seen those stuck in the airway. So they can get anything in their airway. You just have a high index of suspicion. Sorry. It can present with sudden coughing or choking, dyspnea, stridor. If it makes it to the lower airways, they can have wheezing, bronchitis, especially if it's been there for a while. It can cause a pneumonia. If it's been stuck there for weeks. So that's why you have to have a higher index of suspicion for these kids. If they've had like chronic respiratory problems for a long time, you want to start thinking about, is there a foreign body there? Treatment, you want to keep them calm. You want to give them some blow-by oxygen. Don't agitate them. And then you're basically going to call, at our institution, PEDS surgery takes a lot of these out. Some institutions it can be GI or pulmonary, so we usually consult PEDS surgery and they take them to the OR and take these out in the OR under controlled settings. Epiglottitis, we don't really see this. This is probably, I don't know, when's the last time you saw a case, Dr. Muir? I've seen it in an adult one time. It was an unvaccinated adult that was from Asia, but I've never seen it in a pediatric patient. But these would see some of the findings that you would see when you go to intubate them. You can see like their epiglottitis is very swollen, very red, very inflamed. It can come down to this very, very tiny hole. And these are kids that are very, very sick, and they need to be intubated in the OR. You don't want to mess with them. We don't put IVs in them. We usually consult ENT and take them to the OR. It's an upper airway disease and it is an emergency. It's life-threatening bacterial infection of the epiglottitis and surrounding structures. It's pretty rare, age 3 to 7, winter months. And H. flu and strep pneumonia used to be the big organisms that would cause it. But since the Hib and the strep flu vaccines came into play in the early 90s, it's really dropped the incidence of that down, maybe 1 in 1,000 patients a year. And I don't even think that's correct, to be honest with you. Usually it's abrupt. They're toxic appearing. They have fever. They're stridor. They have drooling. They cannot swallow. They're usually spitting out their saliva. And they kind of sit in that tripod position. They don't want to be messed with because that maximizes their airway so that they can open up, keep their airway open and breathe. We're going to, like I said, we're going to take them to the OR. We're not going to agitate them. We're not even going to put an IV. We're not going to get x-rays. We usually would call ENT and send them to the OR, and they would do all that in the operating room. Bacterial tracheitis, this is also rare, probably 1 in 10,000 patients, but it's usually inflammation of the trachea. Usually staph is probably one of the most common organisms. It's an invasive exudative bacterial infection of the trachea. Males are greater than females, 3 weeks to 16 years, and like I said, staph is probably your biggest organism. It has a very similar presentation to croup. There's this one guy that always transfers from some, I can't remember what the outlying hospital is, because he's always worried that these kids have epiglottitis or tracheitis, so he transfers them to Shands, even though they're just croup and they look fine by the time they get to us and can go home. So you want to think about bacterial tracheitis if the kid looks sick, if they're having fevers, even though you can still have fever with croup. But usually these kids are not well-appearing kids. These kids they're sick. They don't want to be messed with. They're hoarse. They do have some respiratory distress. Whereas the croup patient, you give them Decadron and racemic epi, and they're usually running laps around the emergency room. These kids probably would not be doing that. The treatment for them is you want to secure their airway, antibiotics, and that if you think you can do it in the emergency room, you can secure their airway in the emergency room, but you usually need to have your most experienced personnel do that. But a lot of times they need to go to the OR for that as well. And this is just a table that kind of shows you the difference between epiglottitis, croup, and bacterial tracheitis. Croup is usually viral, whereas epiglottitis and bacterial tracheitis are bacterial. You can see the age range, the onset. Croup kids, like I said, they usually kind of come in looking bad, but then by the end they're fine. They're running around the emergency room, whereas the epiglottitis patients and the bacterial tracheitis patients can look sick. Epiglottitis, you have drooling, whereas the other two you don't. Cough usually goes along with croup and bacterial tracheitis, but not epiglottitis. And then you can see hoarseness with croup and bacterial tracheitis. And then as far as the white cell count, it's elevated in epiglottitis and bacterial tracheitis, but not in croup. These are just some more examples of causes of stridor. You can see there's a long, long, long list of them. Not something for really you guys to worry about, but just something to kind of throw out there. Asthma, you guys see a lot of asthma. It's a lower airway disease. It can be an urgency, but it can also be an emergency. And what I mean by that is there's a lot of patients that don't take their asthma seriously. They don't have what we call an asthma plan. So even though the parents call you guys to give them a treatment, they will sometimes refuse. We actually had a kid die in fellowship when I was in training because he was using the Flovent inhaler as his rescue inhaler, not his albuterol. So they didn't really understand the difference. So that's what I mean by an asthma plan. And I will tell you, I think I probably have to go through that with each family. 2/3 of the family that come through, they don't understand the difference between the rescue inhaler versus the inhaled steroids that they're on. You want to see how these kids are breathing, what the respiratory rate is, what's their oxygen saturation, do they have a prolonged expiratory phase, what's their mental status like. We try not to intubate these kids if possible because it takes forever to get them off the machine. If you do, the last one I intubated probably was 6 months ago, and it was a 12-year-old. And the only reason I did is because he got down on all fours to auto PEEP because he couldn't breathe after 3 albuterol treatments. So to me, that's kind of what I mean by what do they look like? How are they acting with treatment?
What is auto PEEP?
So you are increasing, so like we use PEEP on the ventilator to keep the airways open, to keep the alveoli open. So that's what he did. He got down on all fours to increase his auto PEEP, like in his lungs, to keep his airways from collapsing. I've never seen that before.
Sometimes on an adult asthmatic, you'll see them when they breathe out, they'll hold their lips together. What they're doing is they're exhaling against a narrow opening, so they're building up pressure in their airway to hold their smaller airways open. And then, kids will do that more with condition. You'll see that with the oral and then that's just saying, they're not even thinking about it, but their body's saying, I need more oxygen. I gotta keep my airways open.
When you look at them, are they dysmic? What I mean by that, can they talk to you in full sentences? If they're an older child, can they cry? Do they have retractions? Are they tachypnic, nasal flaring? What is their, do they have wheezing? Do they have a prolonged expiratory phase? And you want to be aware of the quiet chest. The quiet chest is usually an asthmatic patient that's probably impending respiratory emergency and failure because they're not moving any air at all. Those are the ones that usually get intubated. Treatment's the same, ABCs, oxygen, nebulized albuterol, steroids, keep them in an upright position. In the severe attacks, you can use sub-Q epi. You can actually put them on an epi drip. Terbutaline, I don't think you guys carry terbutaline. That's the other thing that we sometimes do. And then if I have a severe asthma patient, they all get mag. For the pediatric side, most of those kids, if they get magnesium, they're going to get admitted. On the adult side, it's kind of interesting. If we give mag, sometimes they go home if they get better. But I guess we're just a little more cautious on the pediatric side and admit those kids.
Ms. Yesterday was mentioning using nebulizer injections versus the sub-Q you just mentioned.
If they have stridor with wheezing, because you'll see asthma patients that come in with croup, I will give nebulized epi that way. But if it's a true asthma patient, I personally just use the albuterol, or Duonebs is what we usually do, albuterol with the Atrovent.
Well, we're going to use albuterol first. I was thinking of the severe attack.
Yeah, I would just
so
keep.
What point would we consider switching?
If you think it's asthma, you just keep giving them nebs. Because what we do, if they don't improve with 3 back-to-back nebs in the emergency room, we put them on continuous for 4 hours, and then they wean them off of that. So you just have to monitor their tachycardia, and they're probably going to get really jittery, but that's okay. They can. Most pediatric patients can tolerate that because they don't have the cardiovascular disease that the older adults do.
If you see an asthmatic patient that you're worried about some split breathing, kind of like if you see a severe allergy patient who's wheezing and not breathing, that's kind of an example of somebody that's used that before.
Yeah, you would give it sub-Q, just like you would, or IM, just like you would an asthmatic patient. So like I talked about, many of these patients, and parents don't take their disease very seriously. Even as they get to be teenagers, I think they're probably less compliant. They don't have an action plan. Their albuterol is short-acting. And if they need multiple treatments, they probably need to be seen in the ER because they probably need steroids and maybe even admission. Sounds like an elephant. Bronchiolitis, we are actually coming into bronchiolitis season. I feel like I've probably seen 10 or 15 RSV babies the past several nights that I've worked. So usually these are kids, there may be a family history of asthma. These kids may have a family or a history of reactive airway disease, and what I mean by that is up until 2, you can't be diagnosed with asthma, but they may wheeze with like colds, season changes, or if they have allergies, seasonal allergies. But usually these kids are somewhere between, I would even say, neonates to 2 years. I wouldn't say 2 months, because we see a lot of the babies within the first month of life that come in with RSV because it causes apnea. So the premature and the congenital heart kids are more at risk of having apneic spells and hypoxia. And that's usually less than 1 month old. And it's a virus that causes inflammation, edema, and mucus in the lower airways. It's viral etiology. RSV is the most common, but flu can do it, parainfluenza, all these different viruses. RSV is probably just only the one that we can test for. Even if this kid looks like an RSV baby, bronchiolitic baby, and they don't test positive for RSV, we would still treat them as such. They can come in, they can be dyspneic, they can have tachypnea, they can have retractions, nasal flaring, wheezing. And the wheezing actually sounds different than an asthmatic. It's usually inspiratory and expiratory, and it kind of sounds like musical wheezing to me, like somebody playing a flute is how I would describe it. Whereas when you hear the asthma patient, it's usually expiratory wheezing. They can have a prolonged expiratory phase, rales, rhonchi, decreased air movement. Treatment for this is really just supportive. Oxygen is probably the big thing for them, and suctioning. Suctioning is the first thing that we do when we see these kids in the emergency room. And then there is a whole protocol for using nebulized albuterol, hypertonic saline, and racemic epi. I will tell you, I probably try hypertonic saline first just to help, because it helps get some of the secretions out of their lower airways and helps them cough it up. But suctioning is the best thing that you guys can do when you have one of these patients that you're bringing in, is just suction, suction, suction. It is pneumonia. Probably not something you guys are going to be diagnosing in the ambulance, but they can be, you guys can get calls for these kids that are coming in with an airway at urgency. It's all ages. Usually young patients are very sick, chronically ill, or at higher risk, and it's usually bacterial or viral etiology. Rales are usually localized with rhonchi. They can have tachypnea, plus or minus fever, plus or minus respiratory distress, and plus or minus hypoxia. Treatments, oxygen, fluids, and antibiotic therapy. And some of these kids can actually go home with oral antibiotics. They don't have to be admitted if you can get them feeling and breathing better in the emergency room. So just some practical points. You want to listen with your auscultatory exam. That kind of helps you diagnose the upper versus lower airway disease. Sometimes you don't even need your stethoscope for croup or grunting. Airway urgencies can quickly progress to airway emergencies, and just beware of the neonates. The neonates, I think, probably are the one patient that scare us all, because they can look well 1 minute and the next minute they can get really, really sick. You want to trust your parents, look at your patient, see how they're breathing, what they're doing, what they look like, and then try not to agitate the patient if you think they have a respiratory emergency. Dr. Falgiani also put this lecture together, so I'll credit her for doing that. But this basically comes out of the ATLS book for the pediatric part of trauma. There it goes. So we're going to talk about trauma, why it's important, identify some of the unique characteristics and physiology for children, and kind of review the modified Glasgow Coma score for patients, for infants and children. And the reason why trauma is important is because a lot of these injuries are actually preventable. Probably about 40 to 50% are actually preventable with teaching or home safety, appropriate installation of car seats, making sure you have pool gates up around your pools, different things like that. So it is probably the #1 cause of morbidity and mortality in children from all age groups. Accounts for about 50% of all pediatric deaths, and about 20,000 children a year die from some type of trauma injury. And head injury is usually the leading cause, followed by chest and abdominal. And then 80% of injuries are usually blunt trauma, not penetrating. You see higher penetrating trauma in your cities, like where I trained at for residency and fellowship in Philadelphia, probably New York. Not so much here. Mechanism of injury, like I said, motor vehicle accidents. You want to think about falls, especially children under 5 years of age. Can't tell you how many kids I've seen fall out of like a second or third story window because the window wasn't locked. There wasn't appropriate safety mechanisms. Homicides and suicides are actually becoming more prevalent in teenager population. Child abuse, probably less than 5 is where you're going to see most of that. Drowning is usually less than 5. Sports-related injuries are usually your teenagers, and then penetrating injuries are usually, again, your teenagers, your older children. And like I said, 20 to 40% are usually preventable. Educational activities help, so helmet use, bicycle safety, seat belt, car seats, pool safety, and then just making your parents aware of things that they can do, safety locks, gates, smoke detectors, and then small toys. You want to make sure that they don't give their children small toys because a lot of the kids can choke and die from those. I like this picture. Children are not just small adults. I actually have a picture of my brother with a baby, and he was probably like 18 months old. My dad gave him a beer bottle. So, some of the things you want to think about, they have smaller bodies, so the force from an accident or trauma is generated over their body is usually larger compared to you or I. They have less elastic connective tissue in close proximity of their organs. So basically what that means is when force hits them, because their bones are connective tissue, they're not ossified like ours, usually they're going to have no signs of external injury, they're going to have signs of internal injury. And then they are really predisposed to hypothermia. So the trauma patient that comes in, it's really important to make sure that you keep them warm, transporting them, as well as when we get them. We actually turn our trauma rooms up. We turn the heat up, and it's horrible in there because you're working under stressful conditions, plus you have a hot room on top of that. So these kids are just more prone at hypothermia, and they don't do well if they get hypothermic on top of their trauma. Their skeletons, like I talked about, they're more pliable. So rib fractures are pretty rare. Usually what you're going to see is pulmonary contusions, and you're going to have no signs of ecchymosis or trauma on the outside. You're not going to have crepitus or subcutaneous emphysema like you would in an adult patient. And then they have growth centers, so they can have different types of fractures than what you see in us. And then we talked a little bit about that, just the hypothermia. They just have a higher incidence of heat loss due to their high body surface area. So the A, B, C, D's, E's are always the same. We actually add F in for pediatric patients, and that's for family, and we'll talk about that in a minute. You want to make sure that you can maintain a patent airway if you don't have adequate oxygenation and ventilation, because once these kids start to lose their airway, they're going to code. It's not like an adult. An airway is always first priority. I like this picture. So this is probably what most of you guys think of when you think about having a pediatric airway. You're like, oh my God, what am I going to do? So hopefully I can give you a little bit of hints to help you, make you feel more comfortable with that. So we talked a little bit about these in the last lecture. Because of their large head, they usually have the head down, so it keeps their airways closed. So you want to make sure you put a shoulder towel underneath their neck or their upper area of their back to open up their airway. They have the large tongue. They have the large adenoid tissue, which we don't have, so it's difficult to pass an airway through the nose or to put a nasal trumpet in. Usually their U-shaped floppy epiglottis is harder to intubate with a Mac blade, so we recommend a Miller. But you can, like I said, use your Mac blade as a Miller blade. That's personally what I like to do. I don't like the Miller blade. And then the larynx is more difficult to visualize, so you want to make sure you look up and put cricoid pressure down if you're actually intubating these kids. This is just an example of your Miller blade. It goes below the vallecula and picks up, whereas your Mac blade actually sits in the vallecula and allows you to pick up. And so what I mean by using the Mac blade, you can actually put it below the vallecula and use it as a Miller blade. Anesthesia actually do that a lot in the pediatric population. These are just some blade sizes for different ages. As long you guys carry the Broslow tapes, right, in the ambulances? All this stuff is on your Broslow tape. You don't have to remember it because it's too much to remember, I think. So it actually has drug doses as well as like tube sides for you. Again, the cricoid ring is the smallest in diameter. They have these narrow tracheal rings and short distance between the rings, so it's very hard to get a surgical airway in these kids. It's better if you can actually intubate them. Cartilage is usually softer, more flexible. They have a short tracheal length, so again, you want to make sure when you intubate that the tube goes in 1/3 of the length of the tube, because most of us will just shove the tube in and we're going to right main stem it. And it's also very easy to dislodge these tubes because they are shorter. And then the larger airways are usually more narrow, so you have greater resistance when you're actually oxygenating them. Again, that's just another picture of the airway. So most of these kids, if they're obtunded and you're thinking about intubating them, I always assume, just like an adult patient, that they have a cervical spine injury. And we'll talk a little bit about cervical spine injuries because that does differ in the pediatric patient compared to the adult patient. So you want to make sure that you hold their head in neutral position. You want to look for any obstruction before intubating them. Make sure you clear all the vomit or blood out of the airway. Make sure there's no foreign bodies in there. And you want to think about their level of consciousness. If they have a maxillofacial injury, you're going to have a harder time intubating them, and you're going to have to be very careful. And then you want to see if they have stridor or cyanosis with that. Non-invasive management, you can put them in the neutral position, put the shoulder roll. You can use a modified draw thrust, and then you can bag valve mask them with the oral airway. So you can put a nasal trumpet in, but like I said, it is sometimes harder in the younger kids because of all their adenoid tissue. If you're concerned about intubating them, as long as you can bag them and you can get to the hospital until a more experienced provider can intubate them, that's fine. I know it gets tiring bagging them, but oxygenation is the most important point for these kids. And then usually these kids have smaller lungs, so they require smaller pressure, so you just want to make sure that you're not blasting them with air because you can actually cause barotrauma and pneumothoraxes in some of these younger patients. And this is just an example of how the shoulder roll, when you put it under, how it helps open up the airway and helps put them in the neutral position so that they can breathe better. I will tell you, in most of my patients that I have respiratory problems with, this is one of the first things I'm doing is opening up their airway. Physiology for oxygenation in children. Children have 2 times the consumption that you and I do. Well children have about 2.5 minutes of reserve time, whereas infants have about 2 minutes of reserve time. For adults, that's usually 4. A sick child, they can probably become apneic and blue within 30 to 60 seconds. Those are things to think about. You want to make sure that you're oxygenating them at all times if they're having any problems. They have an increased tendency for atelectasis. They have an increased tendency for interpulmonary shunting and hypoxemia. And then the smaller airways have a higher resistance and are easily obstructed, and they fatigue very fast compared to the adult patients. So pre-oxygenating is very important before intubating these kids. It's usually oral tracheal, never nasotracheal. I don't think I've intubated a nasotracheal kid except for in the OR for some of the ENT procedures, but usually most of these kids are oral tracheal intubations. Uncuffed versus cuff tubes. Do you guys carry cuff tubes? I don't even know that. For the pediatric patient? Okay. I will tell you, most of us are now using cuff tubes in pediatric patients. That whole less than 8 has probably gone away. I feel like the hardest challenge in finding a cuff tube at UF is probably the size, the smaller tubes, the 2s and 3s. We usually just can't find the cuff tubes, so we have to put an uncuffed tube. But I think the tendency now is most patients most practitioners are moving towards cuff tubes, so in less than 8 years of age. But if that's all you have, that's all you have. So this is just the formula. This can't be used in children less than 1 year of age. It can only be used, and I actually don't really like it for 1. I still go by weight, probably under a year of age. I use more of this for the older kids. The Broslow tape, that's why the beauty of it, you don't have to remember that the cuff side or the tube sides will actually be on there as well. And then the visual estimates. Trish doesn't think that you can look at a kid's pinky and use it to guide how big a tube you might need. I think there is some relevance in using it. If you're unsure, it's not going to hurt you. It's just if you have a large air leak with a small tube, you're not going to be able to ventilate the child, so you may have to change the tube out. But your Broslow tape is very helpful. So these are all indications for intubating a patient. If they can't protect their airway because they're obtunded from head trauma, you're concerned that you're going to lose the airway because they may have massive internal injuries and they're bleeding. You can't oxygenate or ventilate them. You know that they're having impending cardiac arrest coming because they are bleeding, significant head injury, or a flail chest. And I've never seen a flail chest in a pediatric patient just because of their ribs are not cartilage. Some of the anatomic and physiological differences in breathing in these kids, you can see infants breathe at much higher rates than you or I do. Children around year 8, they probably become like an adult. They start to breathe around 20 rate per minute. And kids, the diaphragm is usually fatigued and displaced. They have increased compliance of their chest wall and a smaller functional residue of capacity, which means they have a shorter amount of time before they become hypoxic and cyanotic. So you want to look at the chest, you want to see what the chest is doing, you want to listen to your breath sounds, what's the respiratory rate, what's their skin color, what's their oxygen status, and their trachea, is their trachea deviated or not. You want to make sure you give warm, humidified oxygen, again, because hypothermia is such a risk for these trauma patients. That's why we warm our oxygen. Probably not doable in the van, in the EMS van, but once they get to the OR or the ER. And then you want to treat life-threatening conditions. If you think they have a tension pneumothorax, an open pneumothorax, or a flail chest, you want to make sure you needle decompress them and put a chest tube in. The chest tube size is actually on the Broslow tape too, but it's usually 4 times the size of your ET tube, just as a general rule of thumb. So in kids, unlike adults, usually they're going to be tachycardic. If they become bradycardic and hypotensive, that's usually a late sign of shock, whereas most adults that's not the same for them. So usually these kids will, once they become tachycardic, they've usually lost about 1/3 of their blood, so you want to start thinking fluids on them. And by the time you get to the 3rd bolus, you want to start thinking about blood. Because if they become hypotensive, that's usually uncompensated shock, and that usually indicates about 1/2 of their blood loss. And then bradycardia and respiratory arrest is going to follow after that. Circulation, you want to check their pulses, their heart rate, peripheral pulses, what their skin color and temperature looks like, their cap refill, what their level of consciousness is. Are they interacting with you? Are they attended, lethargic? If there's any hemorrhaging, you want to apply pressure, and you want to make sure you replace their circulating volume with fluids. And then vascular access. If you can't get an IV in these kids, IO is your friend. I've put so many IOs in, it's become like second nature. It's really just talking with the parents if the parents are there and explaining to what them doing, because I think the procedure itself sounds more horrible than actually putting it in. And the most common site that we go is the anterior medial proximal tibia. You can use the distal tibia in older kids and the proximal humerus if you have a teenager or adult. Complications that you can see with this is that you can't get if you don't get the needle in, you only have one more site to try on. So you want to make sure that your most experienced provider puts them in. If you failed on one attempt, you can fracture, you can cause compartment syndrome if you have leakage of the fluid into the subcutaneous tissue. And then complications that you can see down the road is infection. That's pretty rare, fat embolism and growth plate injuries. Mm-hmm. Bone starts to form in 7 to 10 days. So I would say probably somewhere a week, 2 weeks.
But cartilage would be laid down before that.
Yeah, and then fluids, 20 per kilo is what we usually do. It can be normal saline or LR. We usually warm it in the emergency room. Again, if you're giving your 3rd bolus, you want to think about ordering blood at that time, because usually that kid is probably bleeding somewhere on the inside. And then you can estimate your child's weight. If the parent doesn't know or you don't know what the child's weight is, you can use your Broslow tape. That's where it becomes your friend. I actually carry a Broslow tape around with me, just in case.
I do too.
You never know.
And it's silly because you can only buy them in lots of 5. So
Mm-hmm.
I don't necessarily buy every new edition, but I got to buy 5 of them at once.
Mm-hmm. Yeah, you just never know when you're going to need it for something. So what you want to see is when you give fluids, you want to make sure the tachycardia is coming down. You want to see that the pulse pressure becomes narrow. You want to see that they have normal skin perfusion, that their consciousness is returning, and then you follow the urine output general rules, 1 to 2 mLs per kilo per an hour. So D is for disability. You want to think about, like I said, the cervical spine injury. So kids younger than 8, their fulcrum of their spine is at C1, C2. The C-spine doesn't become like an adult till about 8 years of age. And because it is so cartilage, most of these kids don't have fractures. They actually have ligamentous injury or damage to the spinal cord itself. So they stretch out those ligaments in the spinal cord, but you see no fractures. And they can present with these funny neurologic symptoms that kind of wax and wane. So you have to have a high incidence suspicion, and usually the way to pick that up is MRI. It's not going to be showing up on your CT scans or your plain films. And what SCOROS stands for is spinal cord injury without radiologic abnormalities. So that basically means they have normal X-rays, they have normal CT scan for bony structures, but their MRI shows damages to the ligaments and the spinal cord. D is for disability. A is, I think it's alert. I always have a problem remembering. Alert, thank you. It's basically the modified GCS for infants and children. You want to look at their pupil size and reactivity, what their extremity movement and tone is. Are they having any posturing? Do they have any reflexes that are abnormal? So this is just the modified GCS. I tell you, this is hard for me to remember. I memorize this for tests and then I throw it out, to be honest with you. But I'm not going to read that to you guys. You can just see how the difference is for less than 1 year, greater than 1 year.
Dr. Colligan said yesterday, you look at, they have less than 1 year, greater than 1 year.
It's not that much.
You may have difficulty getting a child who's terrible to follow command.
That's very true. That is very true. That's just their verbal. Okay. And then E is for exposure. You want to make sure you take all these children's clothes off and take a look at them. The young kid, less than 2, can't shiver. So shivering allows you to decrease your body temperature. So that's one of the reasons why we turn the room up and we make sure that we give them warm blankets, warm fluids, warm oxygen. The larger their body surface area is, the more evaporative heat loss that they have, so the more chance that they're going to become hypothermic. They have less energy reserved, and then they have increased calorie expenditure compared to you and I. So when you take all their clothes off, you want to make sure you log roll them. You want to look under their hair. You want to look under their collar. You want to look underneath their axilla, in between their butt cheeks. I always take all my splints off and look underneath my splints to make sure there's not an open fracture there. And then while you're doing all that, you can have overhead lamps to heat them, blankets to heat them, but usually we just turn the heat up in the room. It's probably the most easiest thing for us to do. And so the mortality actually increases if they become hypothermic with a severe trauma, whether that be a head injury or abdominal or chest injury. And then F is for family. There's actually been multiple studies, and I feel like this is one of the things that UF doesn't do very well, is having family members come in when we have sick patients and we're actually resuscitating them and intubating them. I feel like I get a lot of resistance from the nurses. I don't know how you do, but where I trained at, the family came in on every resuscitation that we had, whether it be trauma or a respiratory code in the field for a SIDS baby or whatever was going on. The family will actually do much better if the child doesn't do well or if the child dies. It actually gives them closure to know that you did everything that you possibly could do for that child before you pronounce them dead. Some family members don't want to come into the room, and that's their choice. But I feel like they have better closure if they actually do. And then you want to make sure that somebody in the team can actually explain to the family what we're doing, what's going on. So that's usually, if you have a social worker available or a preacher, they can usually stand there beside the family member and explain to them why we're doing what we're doing and what we're doing. So you really just have to know the difference between pediatric patients and adults. There's to help to treat them. They have big heads. The lack of outward injury can be very deceptive. They can still have internal injury even though there's no ecchymosis, no fractures there. And then hypotension is a late sign of uncompensated shock, so you want to prevent that. You want to treat them with fluids early and give them blood if they need it. And then make sure that the family gets help during that treatment and can show what is actually being done to them so that they know that you did everything possibly that you could for them. The references, this basically comes out mainly out of the ATLS course manual, which I think we all have taken. And then she lists some other references there.